الله الرحمن الرحيم. برحب بحضراتكم في مراجعة الموديول الثالث بتاع الدبلومة. وفي الأول كل سنة وأنتم طيبين، وإن شاء الله ربنا يبلغنا رمضان ويتقبل مننا الصيام والقيام بإذن الله تعالى. الموديول الثالث هو اليورينري سيستم، وهنعرض على حضراتكم بعض الحالات، وأنا I will comment on the cases in English so that other colleagues can get benefit from these revisions.
Recording in progress.
Then you can answer the quiz on the chat, and I will comment on the answer. And the answer is reflux in the right-sided double collecting system is another answer. And the true answer is this is duplicated right-sided pelvic ileal system and the ureter. And both ureters united approximately at the level of the sacral promontory. And whenever there are some congenital anomalies in the kidneys, then the anomalous kidney is liable for infection, obstructive changes sometimes. And this is a hydronephrotic duplex system with normal appearance of the left kidney. The second case is an ultrasound of the scrotum. Epididymoorchitis is a true answer. Yes, and you got hypervascularity in the testicle as well as in the epididymis, and both are inflamed, and the answer is right. This is an acute epididymoorchitis. The third case is an MRI for the renal area, T2 weighted image and T1 box contrast with fat set image. Yes, the answer is right. This is renal cell carcinoma, and one of the essential findings for the diagnosis of renal cell carcinoma is to assess the extension of the tumor into the renal vein, and also if it reaches the inferior vena cava or not. And in this case, you can see that the tumor has invaded the left renal vein but not yet reached the IVC. This is the renal cell carcinoma with renal vein invasion. The next case is a male, 70 years old. He is a diabetic patient with presented by swelling, pain, erythema in the groin and scrotum with fever. Yes, necrotizing fasciitis is the answer, and the yes for this disease is Fournier gangrene, has this specific name, but if you say this is necrotizing fasciitis, you are right. And of course, this is a severe infection because the patient is diabetic. The next case is an ultrasound of the kidney. Yes, this is right. Emphysematous pyelonephritis is the right answer because you got some echogenic areas within the collecting system, and these echogenic areas do not have a posterior acoustic shadowing to think of calculi, but whenever you got this and you think of air or fat, and this is emphysematous pyelonephritis. This is the selected image from the CT of the abdomen in a male patient, 70 years old. And the answer is right. This is a transitional cell carcinoma of the ureter, right ureter. In the right ureter, you got a soft tissue mass with dilatation of the middle third of the ureter and proximal obstructive changes in the pelvic ileal system, diagnostic of ureteric transitional cell carcinoma. The second case is a CT scan after contrast injection of the pelvis in the region of the urinary bladder, prostate, and rectum. Yes, and the answer is good. This is the prostatic cancer, and in such conditions, you should look for invasion of the urinary bladder and invasion of the rectum. Both are invaded by the tumor. The rectum, the bladder, and of course, the seminal vesicles are also invaded by this prostatic cancer. And this is the CT scan without contrast and the corresponding ultrasound with Doppler facility of the left kidney. Hydatid is right, and the answer is hydatid cyst of the kidney, because one of the classic appearances of hydatid cyst is the presence of a big cystic lesion with internal daughter cysts, as you can see in both ultrasound and CT scan. The next case is a coronal image of the abdomen obtained after intravenous contrast injection. Yes, this is polycystic kidney disease, but the important finding is still polycystic kidney disease with transplanted kidney. And what is the wrong with the transplanted kidney? Thrombose. What is the structure thrombose? Is it the renal vein or the renal artery? Yes, and this is the right answer, and you got these non-functioning polycystic kidneys with multiple hyperdense cysts, and this is the transplanted kidney, which is most likely rejected because of the retained contrast material within the renal parenchyma and the thrombosis of the renal vein. And this is the renal vein thrombosis of a transplanted kidney with bilateral non-functioning polycystic kidneys. And these are a series of images for the kidneys, ureters, and the renal bladder. This is the before contrast injection, after contrast, and the delayed excretory phase. No, this is not TB of the kidney. The kidney is dilated, the calyceal system, with a stone within the dilated collecting system, but the ureter is not dilated, as you can see here, and also you can see in this reformatted image. Yes, and this is pelvic junction obstruction with severe loss of the renal parenchyma and also a stone within one of the dilated calyces. And you see this is the delayed image, axial image, where you got normal appearance of the left kidney and markedly dilated renal pelvis and calyces with almost total loss of the renal parenchyma. Now, yes, and this is an ultrasound of the testis, and you got the answer already is shown in the words below the image, and this is the classic appearance of an epidermoid cyst with the characteristic whorly appearance, and classically this lesion is not painful and not tender and is not vascular as well, with the very characteristic onion ring appearance. This is a classic intratesticular epidermoid cyst. The next case is a male 66 years old with hematuria and right-sided hydronephrosis. Yes, and this is urinary bladder carcinoma with invasion of the ureteric orifice on the right side and the consequent obstructive uropathy on that side. Yes. Okay, and this is the ureteric stent on the left side. Yes. Okay. Whenever you see that the stent is complicated by the development of calculi in the kidney, and the calculi along the course of the stent itself in the ureter, and also calculi in the urinary bladder. This is known as incarcerated ureteric stent. And by incarceration, we mean that the stent has been forgotten for a long period. And you know that ureteric stent has to be replaced every 6 months, unless otherwise you got incrustation of the ureteric stent, and also you got many of deposition of calcium and the stones along the course of the stent. This is known as incarcerated ureteric inc incrust encrusted ureteric stent, encrusted ureteric stent. And then this patient with painful micturition. Yes, and this stone is located along the course of the posterior urethra, and this space is known as the clear space. Many times this space is not included in the plain film, but in the previous days they instructed the junior staff they should include this part of the urethra within the planete for fear of the presence of calculi in such space. And the next case is a film from an IVU series where you got almost normal function of the left kidney, but the right kidney is diseased, and the classic appearance of TB of the kidney or potty kidney because of the extensive calcification within the renal parenchyma and the collecting system, as well as the calcification along the ureter, with some changes on the left side, but less severe, in the form of parenchymal calcification and some amputation or restriction of the calyces. And this is renal tuberculosis. Ultrasound of the scrotum. Yes, and this is epididymitis, The epididymis is the only affected by the disease with hypervascularity, but the testis is not. And sometimes you got orchitis as a separate entity or epididymitis as a separate entity, and frequently you got both epididymo orchitis. And this is the urine bladder catheter, but the rest of the course is not shown. But the problem is not in the bladder. Yes, and this is the right answer. This is the seminal vesicle mass. And this mass is not an inflammatory lesion because of the pattern of enhancement and the clearance of the surrounding fat. Then you have to think of a neoplastic disease, including carcinoma, lymphoma, and metastasis as usual. And this was the seminal vesicle lymphoma as proved by biopsy. And you may be also appreciate this is slightly enlarged internal iliac lymph node as well. This is a male, 69 years old, with a problem in the left kidney. Yes, and this is not a renal cell carcinoma, but this is a transitional cell carcinoma, is a big mass within the renal pelvis. The kidney is markedly atrophic, possibly due to obstructive changes with loss of the renal parenchyma, and the classic appearance of transitional cell carcinoma. Next case is a male patient, 52 years old, presented by hematuria after an assault. Infarcted kidney, yes, and this is avulsion of the renal vascular pedicle. You got excretion of contrast material through the right kidney, but the left kidney is ischemic due to interruption of its blood supply. And this is grade 5 renal injury. Next case is a magnified view from an intravenous urogram. Yes, which type of nephrocalcinosis? Yes, and this is a medullary sponge kidney. You got the classic calcification within the renal pyramids, which is similar to the brush with maintained function of the kidney. And this is a classic appearance of a medullary sponge kidney. Then this patient presented by hematuria after CT-guided renal biopsy. Nephritis? No. Polycystic kidney disease? No. Hematoma? No. Okay, this is an aneurysm, and you can see this is the arterial phase, and the secular dilatation of one of the intrarenal branches of the renal artery, and is seen also in the reconstructed image of the angiogram. Of course, you know that one of the complications of CT-guided biopsy from the kidney is to induce a connection between the renal artery, one of the branches, and the renal vein with the development of arteriovenous fistula and hematuria. Also, one of the complications of the biopsy techniques is to develop a saccular aneurysm of one of the vessel branches, so that we avoid as much as we can to go through the renal parenchyma in the central part of the kidney where the vessels are present. But if we would like to have a biopsy as a random biopsy from the renal parenchyma, we go to the poles of the kidney, either the upper pole or the lower pole, where no calyces are present, away from the calyces. And actually, we usually selected the lower pole because the upper pole, whenever you have sections by CT, it includes the lung basis, and this also presents an obstacle to go through the lung in order to reach the kidney. So the lower pole is the suitable one for the biopsy, and here you can see that blood is going from the renal artery to the renal vein as well, and this is a heterogenic arteriovenous fistula. This is an ultrasound of the scrotum, and I have to say for all of you that the best way for evaluation of the testis and the scrotum is ultrasound, not MRI. And many times we see in the clinical practice, they request MRI, thinking that it will be more beneficial than ultrasound. But in such conditions, if I am going to write a report on these in these MRI examinations of the scrotum, I will ask for scrotal ultrasound to help me to think of the possible pathology. Then scrotal stone is good, and the scrotolith is also good with some hydrocele. All the answers are good. They sometimes call it scrotal pearl, no problem. This patient had a long history. He is 32 years old and has a coronavirus infection. The patient was ventilated, and after 23 days of hospital stay, he was discharged with the normal serum creatinine level. And a week later, the patient presented with severe metabolic acidosis and oliguria with serum creatinine level very high. Then the CT scan of the kidneys showed, yes, and this is bilateral renal vein thrombosis and bilateral renal infarctions, which is one of the complications, as you all know, of the coronavirus infection. It is seen frequently in the lung in the form of pulmonary embolism, but according to the literature, the kidneys are the second most common site to be affected by coronavirus. Then this is selected images from axial T2 and sagittal T2 of the pelvis. The bladder, in the bladder there is a catheter, and yes, this is diverticulum, but what do you think about the bladder itself? This is a vesical diverticulum with debris inside. This is debris, not a soft tissue mass, because of the fluid level you can see. What about the bladder? Yes, and this is cystitis. You are right. This is not a tumor. This is chronic cystitis with diffuse thickening of the urinary bladder wall. And you remember that the normal appearance of the urinary bladder wall muscular layer is a dark signal in the T2, but the tumors of the urinary bladder will show some bright signal on T2 weighted images. And this is just a chronic cystitis with bladder divertically and some debris inside the diverticulum, not a transitional cell carcinoma. Then we have this case of the MRI of the pelvis, and this is T2 and T2 fat sat, diffusion, EDC, T2 coronal, T2 sagittal. Yes, and this is prostatic abscess, multilocular prostatic abscess with classic diffusion restriction and marginal enhancement. Where is the no, when there is no enhancement, but you got bright signal in the T2 and T2 fat sat with severe or marked restricted diffusion, denoting an abscess in the prostate. These are images from the pelvis, CT coronal reconstruction after injection of contrast inside the renal bladder. And this is sagittal and the coronal T2 weighted images of the pelvis. Yes, and this is fistula, not a bladder rupture, but there is direct communication between the urinary bladder and the colon. And when we injected contrast material, it goes through the fistula tract into the adjacent part of the sigmoid colon, and this is colovesical fistula. Then this patient presented by hematuria and hypotension after an accident. Okay, then this is renal laceration, and the laceration has been complicated by injury of the pelvic ileal system with leakage of the urine and the blood in the perinephric space. The delayed film showed leakage of the injected contrast material within the collection around the kidney, and this is corresponds to the diagnosis of urinoma. And because the kidney is shattered with interruption of the renal parenchyma as well as in the collecting system, you can consider this as shattered kidney or grade 4, not 5, grade 4 renal injury, because grade 5 means avulsion of the renal vascular pedicle. These two images from CT scan of the pelvis after injection of contrast material, and the problem is in the, as you can see, yes, and the problem is in the seminal vesicle, and in such a condition you can see that this is an inflammatory lesion. Number one, because of the marginal enhancement. Number two, because of the stranding of the surrounding fat, and this is a seminal vesicle abscess. Then these are two coronal images of CT scan of the abdomen after contrast injection, showing lesion in the right kidney, and this this lesion is cystic, and the diagnosis is multilocular cystic nephroma, and this is right. Bosnian type 3 renal cystic lesion, or what's known as multilocular nephroma. Both answers are good. This is a child 8 years old with progressive right upper abdominal pain and vomiting, and she is suspected to have appendicitis. This is ultrasound and this is CT scan. Yes, and this is Wilms tumor, of course, not an angiomyolipoma. This is areas of breakdown within the tumor with involvement of the right kidney. And in this pediatric age group is the diagnostic of Wilms tumor. These are two coronal images. Let us say nephrographic phase and excretory phase for both kidneys. Yes, the answer is right. The right kidney is smaller in size with irregular parenchymal thickness, and some of the calyces are seen reaching the border or the contour of the kidney, meaning that total loss of the renal parenchyma, focal total loss of the renal parenchyma, which is diagnostic of chronic pyelonephritis. This is a male patient, 33 years old, and this is an ultrasound of his testis. Yes, the answer is right, and this is seminoma because the age is optimal for this tumor, and you got solid lesions within the kidney. This is coronal T2 weighted image of the pelvis. Seminal vesicle invasion by the bladder is not shown here, but I think this is a prostatic cancer that is invading the seminal vesicle, yes. You know that the normal seminal vesicle in T2 weighted image is a fluid containing multilocular structure. But whenever it is invaded by prostatic carcinoma or bladder carcinoma, you got alteration of the normal signal intensity into dark signal in the T2, and that will enhance after injection of contrast material. This is also another case concerning the seminal vesicle. Yes, and this is stones in the seminal vesicle on the right side, and cystic lesion on the left side. You are right. This is seminal vesicle calculi, which is one of the well-known finding in the clinical practice. This is the series of CT scans before contrast, after contrast excretory phase for the right kidney, showing this is not renal cell carcinoma. We sometimes cannot differentiate between transitional cell and renal cell carcinoma, but if you see that part of the tumor is located within the collecting system, it is better to diagnose transitional cell carcinoma instead of renal cell carcinoma. Then this is a male patient, 43 years old, with a history of a scrotal trauma. This is a classic appearance, of course. Yes, and this is a hematocele or scrotal hematoma with the classic appearance of internal septations. This is a male, 25 years old, and he has a palpable right upper quadrant mass on physical examination, and this is the scanogram obtained for the CT, and this is body kidney or TB kidney. This is the CT scan of the same case. It shows totally calcified kidney with no function, and posterior pararenal collection that is marginally enhanced, representing a pararenal abscess. And this is MRI T1, T2, and T1 post contrast of the kidneys. No. Yes, renal cell carcinoma on which side? Yes, and this is left-sided renal cell carcinoma. The kidney is involved or infiltrated by mass with nodular stranding of the perinephric fat, denoting fat invasion. And if you look carefully around the aorta, you got bulky lymphadenopathy that shows contrast enhancement after injection of contrast, representing metastatic nodes. Then this kidney, this tumor, has invaded the perinephric fat and had metastatic retroperitoneal lymphadenopathy. This is a child with a big abdominal mass. No, this is not hydatid cyst. Nephroblastoma, there is no solid component. There is no solid component for Wilms. Multilocular nephroma, صح. This is the a big lesion in the left kidney with the characteristic claw sign appearance. The lesion is mainly or totally cystic with internal very fine septations, the classic of multilocular cystic nephroma of renal origin because of the claw sign, as you can see. Then the next case is a CT scan of the abdomen with contrast, intravenous contrast injection, and you got a mass in the right kidney. And no, this is not an abscess. I should say that a mass containing fat in the kidney should be diagnosed as angiomyolipoma until proved otherwise, because renal liposarcoma is considered extremely rare. Then whenever you see a fat containing lesion in the kidney, and you got some of the soft tissues surrounding the kidney which may represent hemorrhage due to the vascularity of the lesion, then there are 5 lesions containing fat in the kidney, including the lipoma and angiomyolipoma, the liposarcoma, the dermoid cyst, and the xanthogranulomatous pyelonephritis. The most common of these 5 is the angiomyolipoma of the kidney. The next case is the plain film and the CTUT of the abdomen. Yes, and actually, I presented this case to show you that there is no limit for the size of renal or ureteric or vesical stones. This patient had many stones in the kidney and a very big stone in the ureter with proximal dilatation of the pelvic ileal system. Then you should not diagnose this as, let's us say, TB of the kidney or TB of the ureter. These are just calculi within the collecting system. But also one of the findings that I have forgot, which is the wide separation of the pubic symphysis, which is diagnostic of ectopia vesica. And next case, you got some calcium in the urinary bladder and also calcification and the strictures along the ureters on both sides with consequent dilatation of the collecting systems. This is classic for bilharziasis. This is classic for bilharziasis. In order to diagnose TB, you should see parenchymal renal calcification. But whenever you see calcium in the urinary bladder, especially if the bladder is maintaining its capacity, because one of the major findings of TB of the urinary bladder is to reduce the bladder capacity markedly and also to reduce the ureteric caliber. But bilharziasis will result in calcification of the urinary bladder, the ureteric wall, and may reach the collecting system, but the caliber in most of the cases is maintained. And this is urinary bilharziasis. And here you got a male patient with 65 years old. And there are bilateral renal masses. And before you jump for the diagnosis of lymphoma, you should think thoroughly of what happens to the perinephric fat, and also if you can see some lymph nodes in the retroperitoneum, and also you see some ascites, then what do you think? Yes, I congratulate Salim for the diagnosis of deposits. Actually, you know that this rule that I have settled, whenever you are looking to a lesion in a certain area, let us look at the lesion in the kidney. Then you know that this lesion is not an inflammatory lesion. This is a neoplastic pathology. Then you think of the primary lesion that can occur in this kidney, which is renal cell carcinoma. Then the next is lymphoma, and the next is metastasis. Then if you consider the lesion on the opposite side, then you may say that this is renal cell carcinoma with metastasis to the opposite kidney, or this is renal lymphoma with involvement of both kidneys, or this is metastatic deposits of unknown primary to both kidneys, and this was the situation, metastasis of high-grade carcinoma of unknown origin after they biopsied these masses. So this is the logic thinking. You think first of the primary lesion, then consider the possibility of lymphoma, then consider the possibility of metastasis. Thank you very much.